Hello, and welcome to part 2 of urinary system pathology. We are going to begin part 2 with another congenital anomaly known as supernumerary kidney. And again, this is a congenital anomaly, meaning the patient was born with this. And in this condition, the patient is born with one or two additional or accessory kidneys. And this is a pretty rare condition. Some of my research shows that there are less than 100 cases of this documented in the United States. Again, it's congenital, meaning the patient is born with it. You can see on the diagram here, here's the right kidney, here's the left, and then here is the supernumerary or additional accessory kidney. When you look at the IVU here, you can see here is the right kidney, here is the left. And then wait a minute, you can see this ureter coming filled with contrast. So this is the accessory kidney. Now everything still functions normally. There's generally no health concerns with this, but just something to be aware of. So let's talk about some other renal pathologies. Polycystic kidney. Polycystic kidney disease is a disorder characterized by multiple cysts scattered throughout one or both kidneys. And this disease is the most common cause of enlarged kidneys. Its cause may be genetic or congenital, depending on the type of polycystic disease, and the cysts will eventually alter the function of the kidney. And you can imagine when you look at this photograph, all of these cysts scattered throughout the kidneys is of course going to inhibit normal function of that kidney. Polycystic disease is often described as a bunch of grapes scattered throughout the kidney, and you can see that appearance there in the x-ray. Polycystic symptoms include renal hypertension, proteinuria, and signs of chronic renal failure. So again, lab works would indicate that the kidneys are not functioning properly, perhaps diminished urine output, etc. If a cyst ruptures into a calyx, it could even produce hematuria. Cysts may be seen during an IVU, but really CT is going to be our modality of choice to demonstrate these radiolucent cysts. We could also use ultrasound as well. And cysts are typically very circular, very well defined. You'll hear that term a lot. They have a well-defined margin. That means it's a nice, perfect circle, typically just filled with fluid. Remember, having a cyst in and of itself is benign, but what happens is all of these cysts, again, begin to alter how the kidney functions. So without one good kidney, these patients have to, begin dialysis and eventually go on a kidney transplant list. And without a kidney transplant, dialysis, the lifespan of a patient on dialysis is about 10 to 12 years. So if the patient is reaching kind of the limits of their dialysis and they don't have a kidney transplant, unfortunately, this will be fatal. So pretty sad. Okay, next let's talk about neoplasms. Remember, neoplasm means new growth, and it could be benign, such as a cyst, or it could be malignant, such as a renal carcinoma or a Wilms tumor, which we'll talk about. So renal cell carcinoma is the most frequent type of malignant tumor of the kidney. It is 3 times more frequent in males than in females, and symptoms include flank pain and hematuria. The tumor itself is typically a large, irregular-shaped mass with internal areas of tissue death or necrosis and hemorrhage or bleeding. So that is the difference between a cyst and a tumor. Typically a cyst has a very, well-described circular margin, whereas a tumor will have kind of an irregular shape here. The margins won't be nice and pretty like a cyst. Okay. IVU may demonstrate reduced excretion of contrast media due to the tumor involvement in the kidney, but ultrasound and CT are the modalities of choice for demonstrating the extent of the tumor growth and its impact on the surrounding tissue. Bladder carcinoma is a tumor that is 3 times more common in males than in females. This tumor is usually diagnosed after the age of 50, and symptoms of bladder carcinoma include hematuria and frequent urination. A cystogram, which we'll talk about in a little bit, a CT or an MRI can be used to stage the tumor and determine the extent of tissue involvement. So again, taking a look at our CT scan here, you can see the right kidney has got some type of irregularity here. We would be concerned that that is a tumor. The other thing I want you to know is that a cyst has no blood flow. So you would never see contrast go to a cyst. So let's look down here. You see this left kidney here? Do you see how this irregular shaped thing has spots of white? That means it has blood flow and it's getting contrast. That is very concerning that that is a malignant tumor because tumors have blood flow. Look at this. This does not have blood flow. That is likely a cyst. There's no white in there. There's no contrast getting to that. So that is how radiologists often differentiate between tumors and cysts. They look for blood flow. Okay, and you can see the patient here has a large tumor in their right kidney as well. Here's another example of a kidney tumor. Again, you can see here it's irregular in shape, and there is some blood flow here. It's certainly not as healthy as the rest of the kidney, but there is some scattered white in this tumor. So again, that's concerning that that's a tumor, not a cyst. Okay, next, Wilms tumor. Wilms tumor is a rare kidney cancer that primarily affects children. It is also known as nephroblastoma, and Wilms tumor is the most common cancer of the kidneys in children. Wilms tumor most often affects children around the ages of 3 to 4 and becomes much less common after the age of 5. The Wilms tumor most often occurs in just one kidney, as you can see here in this CT scan. However, it can be found in both kidneys at the same time. Improvements in the diagnosis and treatment of a Wilms tumor have improved the prognosis for children with this disease, and the outlook for most children with a Wilms tumor is very good. The Wilms tumor doesn't always cause signs and symptoms, but children with Wilms tumor may appear healthy, and again, because they can't always articulate their symptoms to you, things to watch out for are abdominal swelling, an abdominal mass that maybe you can feel or palpate, abdominal pain, fever, and certainly blood in the urine or hematuria. Okay, so we are learning in this unit how to image the urinary system. And because we're going to use contrast to study the function of the urinary system, there's some considerations before we begin these types of procedures. So first, we want to make sure that the patient is giving informed consent. Do they understand the procedure? How old are they? Certainly if they're a minor, they need to have a parent with them or a guardian. Are they mentally competent? If not, they need to have someone who is representing them and can understand the risks of this procedure. And then it's always important that we're obtaining a good history. So why are we doing this exam? What are the previous procedures or surgeries for this patient? Any medical history that we need to know about? And then, of course, any allergies, because we are giving these patients contrast, and some patients do have allergies to iodinated contrast. So we need to make sure we're covering those before we administer the contrast. So a couple procedures that I want you to be familiar with. The cystogram. This is an exam of the bladder that rules out tumors, bladder stones, trauma, or other anatomic abnormalities. So first, you're going to take a scout of the bladder. So that just means a plain X-ray before contrast is administered. Then the patient is given contrast via a catheter in the urethra, and Reno M-dip is just a typical contrast that you could use for this exam. The radiologist will then fluoro. You might do some overhead imaging with your X-ray tube, so you might do some APs, some obliques, a lateral, And again, we're looking for any filling defects. So in other words, the contrast should fill the bladder completely, and normally if you see any kind of abnormalities, that could be a sign of a tumor or something else. So a cystogram is an examination of the bladder where we administer contrast through the urethra. Here is an example of a cystogram taken during CT. So a catheter is advanced up the urethra, and then contrast is administered into the bladder. Then the patient goes into the CT scanner. Here's what I'm talking about with a filling defect. You can see all of this is normal, and then wait a minute, the contrast isn't filling this part of the bladder because it's likely a tumor. And so you see that kind of irregular shape, that's called a filling defect. And again, we'd be concerned that that could be a tumor. Okay, the next exam I want you to be familiar with is a VCUG. It stands for voiding cystourethrogram. A voiding cystourethrogram is very similar to a cystogram. Contrast is advanced up the urethra via a catheter, and the bladder is filled with contrast. The difference here is the patient is asked then to void or urinate on the table while the radiologist fluoros. And what they're looking for is reflux of urine or contrast back up into the ureters. And that can be a cause of chronic or frequent UTIs. These types of exams, the VCUG, are most often done on children who are having chronic UTIs. And again, we want to evaluate what's causing those UTIs. So imagine you might have a 4-year-old. You know, the parents have spent years trying to potty train this child, and then you ask them to pee on the table with all these people watching. It's very uncomfortable. And on top of it, they have a catheter in their urethra. It's a very uncomfortable exam. Children hate it. They cry the whole time. But the patient, again, will void, the radiologist will fluoro, and they'll look for reflux back up into the ureters. So let's look at an example. Here's a VCUG. You can see the bladder is filled with contrast. The patient is asked to urinate or void on the table. And then you can see here, during the process of voiding, there's actually reflux back up this right ureter all the way into that kidney. So certainly that's going to bring bacteria up into that ureter and that kidney from the bladder and cause those chronic UTIs. All right, retrograde pyelogram. So this is a surgical procedure where the physician injects contrast into the ureter in order to visualize the ureter and the kidney. The flow of contrast from the bladder to the kidney is opposite the usual flow of urine, of course, hence the retrograde name. Oftentimes this exam is done to visualize renal calculi. So same thing, the catheter is inserted via the urethra. There is a wire or a catheter fed into the bladder, up the ureter, all the way to the pelvis. Contrast media is then flushed into that catheter, and if there's a calculi present, it's often flushed loose and they can remove it. Our role is to use the C-arm during these exams to help the urologist visualize the urinary anatomy. We may have to do KUBs afterwards. But again, our job is to help image and show that contrast as it progresses from the kidney to the bladder or vice versa. All right, we're going to pause here. If you have any questions about urinary pathology or examinations, please let me know. Thank you.